Welcome back to another video of the Academy. This video is about adductor canal block and the other blocks related to the adductor canal anatomy. So this is going to be a very big video, so I split the video into two parts. We have first part which will cover the anatomy, the clinical implications and the indications for giving these blocks. And in the second part, that is an upcoming video, we will discuss about the techniques and troubleshooting and complications related to this block. So basically we will cover around 3 or 4 blocks related to the adductor canal, that is the adductor canal block itself, the saphenous nerve block in the adductor canal, then we will cover the 4-in-1 block or the modified 4-in-1 block, and we will also see the distal femoral triangle block along with the adductor canal block, which is called as the dual subsartorial block, which is going to be the latest and the most effective block for total knee replacement, postoperative analgesia and other knee procedures. So the major portion of the knowledge for this video has come from my mentor Dr. Karthik Sonavane sir. He is practicing as an anesthesiologist in Ganga Hospital, Coimbatore. It is one of the most famous regional anesthesia training center in India and in the world. So let's go for the video. Adductor canal block is one of the most commonly performed block for total knee replacement, postoperative analgesia and for the sake of blocking the saphenous nerve in the adductor canal. So if we see the total knee replacement, postoperative analgesia, the options itself we have epidural analgesia, periarticular injections, femoral nerve block, adductor canal block and the systemic analgesic options. So the disadvantages of the other blocks or the systemic analgesic is what makes the adductor canal an attractive option, and that is why it is the most commonly performed block for total knee replacement, postoperative analgesia. So it was formulated in 2009. It came actually as a motor sparing alternative to femoral nerve block, which was one of the most commonly performed block till then. So let's go for the anatomy related to the adductor canal and the subdivisions of the adductor canal we'll see in that. Adductor canal is otherwise called as the hunter's canal or the subsartorial canal. It is actually seen in the anteromedial part of the thigh. So it extends from the apex of the femoral triangle till the adductor hiatus, which is an opening in the adductor magnus muscle. So what is the apex of femoral triangle? The apex of femoral triangle is the area where the medial end of the sartorius and the medial end of the adductor longus muscle meet. So that is the beginning of the adductor canal. And the distal end is the adductor hiatus, which is an opening seen in the adductor magnus, where the all contents pass through and go into the popliteal fossa to become the popliteal contents. So if you see the sartorius muscle, it descends in the anterior part of the thigh from the lateral end to the medial end. So anywhere in the anteromedial thigh, if you keep a probe or if you keep the ultrasound probe anywhere in the anterior medial thigh, you will see the sartorius as a roof. The sartorius, if it's seen in cross section, it is seen as a trapezoid or oval shaped structure which forms the roof of the femoral triangle in the distal part, or it forms the roof of the adductor canal. So if you see the other borders of the adductor canal, it is a triangular canal. The roof is formed by the sartorius muscle. The posterior border is formed by the adductor longus muscle in the upper part, and later in the lower part or in the distal adductor canal, it is formed by the adductor magnus muscle. The lateral boundary is formed by the vastus medialis muscle. So these are the 3 boundaries of the adductor canal. If you see the contents of adductor canal, we have the femoral artery which is seen deep to the sartorius muscle. Then we have the femoral vein which is seen further deep to the femoral artery. Most of the time, as you know, vein it will be compressed because of the ultrasound probe pressure. So if you leave the probe pressure little bit, we can easily identify the vein. Next important structure which is seen in the adductor canal is the saphenous nerve, which is seen lateral to the femoral artery. Another important structure which you have to see in the adductor canal is the presence of a vasoadductor membrane, or sometimes called as vastoadductor membrane. It is an aponeurotic membrane which connects the vastus medialis muscle and the adductor longus muscle. So as the name indicates, vastoadductor membrane. So this is seen just deep to the sartorius muscle and just superficial to the femoral artery. It is in between the sartorius and this vastoadductor membrane we see the nerve to vastus medialis and the subsartorial plexus. So any local anesthetic you inject into the adductor canal, it is going to spare the subsartorial plexus and the nerve to vastus medialis. That is the importance of the vasoadductor membrane which you have to know, which is seen in the adductor canal. 2 important neural structures which you are going to see in the adductor canal is, first is the saphenous nerve. You know it is a terminal continuation of the femoral nerve. Then you have the nerve to vastus medialis, again a branch coming from the femoral nerve. The importance of nerve to vastus medialis is, even though it is a motor nerve, the part of the nerve to vastus medialis which is seen in the adductor canal is only a sensory component. The motor component, which already supplies the vastus medialis, would have left in the femoral triangle itself. So the adductor canal will contain mainly the sensory part of the nerve to vastus medialis. Another important anatomy which you have to see in relation to the saphenous nerve is the course of the saphenous nerve. Same like how sartorius is going from the lateral end to the medial end of thigh, the saphenous nerve is initially seen lateral to the femoral artery. So in the proximal part of adductor canal, it is seen lateral to the femoral artery. As it descends down, it crosses anterior to the femoral artery and then comes and reaches the medial side of femoral artery and then leaves the adductor canal. So it is very important to know these relations, especially when you are giving a saphenous nerve block. You have to direct the local anesthetic on the lateral side of the artery if you are giving in the proximal part. All these structures, the femoral artery, femoral vein and the saphenous nerve, can be visualized at a depth of around 2 to 3 centimeters in a normal individual, and maybe another few extra centimeters if the patient is very obese. Another thing what we have to understand is that the nerve to vastus medialis and the subsartorial plexus is not visualized as such. From the anatomy which we have discussed till now, we can understand that the sartorius forms the anteromedial part of the thigh, so it can be seen as a roof of the structures in this part. So the distal femoral triangle, the adductor canal, everywhere the sartorius is seen as the roof. So all these areas are called as subsartorial planes, and if you give the block in this plane, it is called as subsartorial blocks because we are going to deposit the local anesthetic deep to the sartorius muscle. So if you see the subsartorial plane, we can basically divide it into distal femoral triangle and the adductor canal part. The adductor canal can be further subdivided into proximal, mid and distal parts. If you see the distal femoral triangle, it is 1 to 2 cm proximal to the apex of the femoral triangle. So what contents you can see here? We can see the femoral artery. Deep to that you can see the femoral vein. Lateral to the femoral artery and vein we can see the saphenous nerve. Further lateral to the saphenous nerve we can see the nerve to vastus medialis. The importance of this distal femoral triangle is the absence of vasoadductor membrane. There is no vasoadductor membrane at this distal femoral triangle. So local anesthetic deposited near the artery will affect the nerve to vastus medialis as well. Coming to the proximal adductor canal. Proximal adductor canal is a point around 1 to 2 cm distal to the apex of the femoral triangle, again the meeting of the medial end of the sartorius and medial end of adductor longus. So importance of this part is that you have the vasoadductor membrane here. So the femoral artery, the femoral vein and the saphenous nerve can be seen deep to the vasoadductor membrane. The subsartorial plexus and the nerve to vastus medialis is seen superficial to the vasoadductor membrane. The nerve to vastus medialis is seen just in a groove between the sartorius and the vastus medialis muscle. Saphenous nerve, as you know, in the proximal part it is seen lateral to the artery. Coming to the mid adductor canal, how you identify mid adductor canal? It is where the adductor longus muscle in the posterior border starts receding and it is replaced by the adductor magnus muscle. Then you have the saphenous nerve which crosses anterior to the artery and then it starts piercing the vasoadductor membrane along with the descending genicular artery, which is a branch coming from the femoral artery. So saphenous nerve and the descending genicular artery pierces the vasoadductor membrane and it is ready to leave the adductor canal in the mid adductor region. Then the femoral artery and the femoral vein can be seen as usual. We can see the subsartorial plexus and the nerve to vastus medialis above the vasoadductor membrane. Distal adductor canal is identified as a part of the adductor canal distal to the origin of descending genicular artery. The importance is that the vasoadductor membrane is still present, so subsartorial plexus and the nerve to vastus medialis is going to be superficial to that. There are no neural structure inside the canal because the saphenous nerve would have left the adductor canal in the mid adductor canal region. The only neural structure which you are going to see in the distal adductor canal is the posterior division of obturator nerve, which is seen only in the distal part, that is towards the adductor hiatus. Other than that, there are no neural structures visualized inside the adductor canal in distal adductor canal. Now, as you have seen the subsartorial planes at different levels, let's see a graphical longitudinal section. So let's consider this as the distal femoral triangle and the adductor canal. The proximal 1/4 we will take it as the distal femoral triangle. The part distal to it is the whole of the adductor canal, which is again subdivided into proximal, mid and distal adductor canal. The main difference between the distal femoral triangle and the adductor canal is the presence of vasoadductor membrane. If we take the distal femoral triangle, two important neural structures which you are going to see is, one is nerve to vastus medialis, second one is saphenous nerve. The nerve to vastus medialis, when it continues distally, in the adductor canal it is seen in the plane between the sartorius and the vasoadductor membrane, and somewhere in the mid adductor canal it leaves the adductor canal. If you see the saphenous nerve, distally it continues into the adductor canal, that is deep to the vasoadductor membrane. Again at the mid adductor canal level, it pierces the vasoadductor membrane and leaves the adductor canal there. Then within the adductor canal, between the vasoadductor membrane and the sartorius muscle, we are going to see the subsartorial plexus, and we can see the obturator nerve which is seen only in the distal part of the adductor canal, that is again near the adductor hiatus, and it just leaves into the popliteal plexus. So now let's see the effect of depositing local anesthetic in each part. So if we deposit the local anesthetic in the distal femoral triangle, the drug is going to block the nerve to vastus medialis and the saphenous nerve then and there itself. Then distally it is going to spread into two parts, both above the vasoadductor membrane and below the vasoadductor membrane. So it can block the subsartorial plexus there and the peripatellar plexus, which is again seen in this plane, and in the deeper part it is going to block the saphenous nerve. Normally in the distal femoral triangle we give only 10 to 20 ml of the drug, because if you give large volume it can cause proximal spread and you can have a femoral nerve block which can lead to motor weakness. So we restrict to 10 to 20 cc. So this much volume of drug given in the distal femoral triangle will not go through the adductor canal to reach the popliteal plexus. So obviously popliteal plexus is going to be spared with the distal femoral triangle block. Now let's see the proximal adductor canal. If we deposit the local anesthetic in the proximal adductor canal, the drug will go distally through the adductor canal to adductor hiatus and then reach the popliteal plexus. What we have to understand is that the sartorius and the vasoadductor membrane, they are lying so closely that it is very difficult to inject the local anesthetic in between these two. So ideally the structures which are seen in between these two, that is the nerve to vastus medialis, subsartorial plexus and the medial end of the peripatellar plexus, all these are going to be spared if you are going to give a proximal adductor canal block. But the advantages of giving a proximal adductor canal block is that 10 to 20 cc volume given in this part can go and spread distally through the adductor hiatus to involve the popliteal plexus. So the part which was spared in the distal femoral triangle block can be covered with a proximal adductor canal block, and the part which is spared with the adductor canal block can be blocked with the distal femoral triangle block. That is why we combine these two blocks to form the dual subsartorial block. Now if we deposit the local anesthetic in the mid adductor canal, the nerve to vastus medialis, the subsartorial plexus and the medial peripatellar plexus, everything is above the vasoadductor membrane, so those will be spared. And the saphenous nerve would have left the mid adductor canal, so that may also get spared. The only two nerve structures which are going to get blocked is the drug will go distally through the adductor hiatus and there it can block the posterior obturator nerve, and further deep into the popliteal plexus and which can get blocked there. So these are the only neurostructures which can get blocked with mid adductor canal. So this can also be combined with the distal femoral triangle block to get the dual subsartorial block, but we usually give proximal adductor canal block because more we go distal, we are going to be near the surgical site. So for the concern of infection, we are not going into that. So we will combine only proximal adductor canal block with distal femoral triangle block. So what we have to understand, the saphenous nerve has left the adductor canal in the mid adductor canal. So if we are going to give an adductor canal block for the purpose of blocking the saphenous nerve, we have to give it in the proximal adductor canal. So just identify the apex of femoral triangle, come 1 to 2 cm distal, that is the proximal adductor canal. Inject the local anesthetic in a very minimal volume around 5 to 10 ml lateral to the femoral artery. You can block the saphenous nerve. Second thing we have to see is, initially people used to give only adductor canal block for the total knee replacement postoperative analgesia. So from this anatomy you would have understood that if you give only adductor canal block, obviously the nerve to vastus medialis, the subsartorial plexus and the medial peripatellar plexus will be spared. So patient will have postoperative pain. That is why we have come with the latest dual subsartorial block. So if you see the distal adductor canal, the block in that level is given for the 4-in-1 block. The 4 nerves which are blocked in the 4-in-1 block is, one is nerve to vastus medialis, second is saphenous nerve, then you have the obturator nerve, and finally the sciatic nerve. So from the anatomy you have understood till now, it is clear that the saphenous nerve and the nerve to vastus medialis is in a different plane, because saphenous nerve has already left in the mid-adductor canal level and the nerve to vastus medialis is already above the vasoadductor membrane. So if you give a local anesthetic here, these two nerves are going to be spared, that is for sure. So initially, even though the author has termed it as 4-in-1 block, later he realized that the sparing is going to happen, and then he has modified his technique to modified 4-in-1 block. Here what he is doing is that an additional peripheral nerve stimulator guided injection to cover the nerve to vastus medialis above the vasoadductor membrane is done, and then he injects the local anesthetic rest off into the adductor canal. The advantage of 4-in-1 block is that the drug will slowly seep into the adductor hiatus and then into the popliteal fossa to block the sciatic nerve. So the slowly seeping drug will block the sciatic nerve over around 45 minutes to 1 hour time. And by the time the drug reaches there, the concentration will be enough only for the sensory blockade. So 4-in-1 block can be used for postoperative analgesia for knee and below knee procedures. And if you can combine with the saphenous nerve block, can cover the entire lower limb below the knee. Let's see the innervation of the knee joint for the better use in the total knee replacement postoperative analgesia. The knee is basically supplied by the branches from the lumbar plexus and the sacral plexus. Three main nerves which are involved are femoral nerve, obturator nerve and the sciatic nerve. The femoral nerve will cover the anterior knee, obturator nerve will cover the posteromedial knee, and the sciatic nerve will cover the posterior knee. These nerves will innervate the knee directly as well as through formation of plexuses. So there are three main plexuses which are important when we consider the innervation of knee joint. One is subsartorial plexus, then you have the popliteal plexus, then we have the peripatellar plexus. If you see the formation of subsartorial plexus, it is formed by the four nerves. We have the medial cutaneous nerve of thigh, which is a branch of femoral nerve. Then the infrapatellar branch of the saphenous nerve, which is again coming from the femoral nerve. Then we have the cutaneous branch of the anterior division of obturator nerve. Then we have the medial retinacular nerve, which is a branch coming from the nerve to vastus medialis, which is in turn coming from the femoral nerve. So all these nerves will form the subsartorial plexus. The subsartorial plexus is seen in the adductor canal part, deep to the sartorius, above the vasoadductor membrane. The subsartorial plexus will cover the anteromedial aspect of the knee, including the skin, subcutaneous tissue. It will cover the retinaculum, the collateral ligaments and the capsule of the knee joint in this part. Next, coming to the popliteal plexus, it is seen in the popliteal fossa. It is formed by the articular or the genicular branches coming from the sciatic nerve, tibial nerve, common peroneal nerve and posterior obturator nerve. The popliteal plexus will innervate the intra-articular structure like retinaculum, the collateral ligaments and the capsule of knee joint. Next important plexus associated is the peripatellar plexus. It is formed by the branches from the femoral cutaneous nerve. We have the medial femoral cutaneous nerve, intermediate femoral cutaneous nerve and lateral femoral cutaneous nerve. Then we have the medial retinacular nerve, as said, it comes from the nerve to vastus medialis. Then we have the lateral retinacular nerve, which is a branch from the sciatic nerve. Then there is the infrapatellar branch of the saphenous nerve and the nerve to vastus medialis itself. So all this forms the peripatellar plexus and it will cover the skin and subcutaneous tissue over the patella, that is anterior to patella, superior to patella, inferior to patella, medial and lateral to patella. The skin around the patella and subcutaneous tissue around the patella is covered by peripatellar plexus. The medial peripatellar plexus is found in the same site as the subsartorial plexus, that is in the adductor canal between the sartorius and the vasoadductor membrane. So when we give a distal femoral triangle block, the drug will go above the vasoadductor membrane. So along with the nerve to vastus medialis and subsartorial plexus, it will block the medial peripatellar plexus as well. So this will cover the medial part of the knee. So the anterior medial part, skin, subcutaneous tissue, everything will be covered by the blockade of medial peripatellar plexus. The lateral peripatellar plexus is not blocked by these blocks, but the lateral side is not usually involved with the skin incision or the tissue dissection when associated with the total knee replacement. So sparing the lateral peripatellar plexus is not much of a clinical significance. Let's see the pain generating parts of the knee joint so that we can have a clear idea about the blocks and their effects. So if you see this picture, in this The outermost layer is shown as the skin and the subcutaneous tissue. Further deep layer is the muscle layer, and further deep is the bone, that is you have a capsule just surrounding it, then inside you have the meniscus and the collateral ligaments. We can see the pain generating parts of the knee joint before surgery in an arthritic knee and in the post-operative part. In the post-operative part, these are the areas which come in the pain generation. So if you are giving an adductor canal block alone, as I said, which we are commonly using till now, only this much area will be blocked and you can have sparing of this much area. So that is why we give distal femoral triangle block. If you give only distal femoral triangle block, this is the area which is covered and this is spared. So we have to combine the distal femoral triangle block along with the adductor canal block so that we can have a full coverage. So that will cover this much area which is involved in pain generation. So this is the anatomy related to the distal femoral triangle, the adductor canal. This is the full knowledge which you have to know when you are giving these blocks. So here I have covered everything related to the anatomy part. In the next coming video, we will see the technique and the troubleshooting and the complications. So until we see next time, thank you.